struggle with self-doubt. Yes, okay.
We're all dinosaurs.
Some of us are dinosaurs. But anyways, go ahead, Amy.
I know those are always the things that take the longest in my talks, is trying to figure out the most appropriate cartoon. Can you see the main screen?
Yes.
Okay,
Yeah,
perfect.
it looks good.
All right, sounds good. Okay, so I'm going to be talking about 1-year outcome trajectories among survivors of actually severe intracerebral hemorrhage. And this topic actually comes from a JAMA Neurology paper that was published a few months ago from a group at Hopkins, essentially with the same title, so 1-year outcome trajectories and factors associated with survivors of intracerebral and intraventricular hemorrhage, specifically with initial severe disability. And so why does this matter? So I think we all kind of know most of this, but there are greater than 3 million patients with intracerebral hemorrhage each year. And though, there's lower incidence than ischemic stroke, there's certainly 50% greater worldwide burden of disability, which is kind of captured in this graph here, which shows the contribution of specific causes to the combined burden of neurologic disorders as measured by percent of total disability adjusted life years. And so hemorrhagic stroke kind of has that largest contribution. It has a very high 30-day case fatality rate. And kind of because of all of these things, obviously clinicians use clinical severity scores early and as we all know, inaccurately to estimate risk and outcomes for how these patients are going to do. And so that's kind of some of the background of where this paper emerged.
So can I just ask, is that for worldwide, or is that for?
It is, yeah. Yes, yeah, that's worldwide.
Yeah, there's a nice paper that just came out last year looking at DALYs and stroke types and looking at high, middle, and low income countries. It's really pretty interesting. It's a burden. Yeah. It's one of those burden of disease papers on stroke.
Perfect.
I'll put the reference in the thing, but it has some great figures.
Yeah, that's great. I couldn't find something that represented that more recently than this one, which was 2014. So that's awesome. I must have missed that. All right, so kind of a little bit more about the background of this. And so what is the main problem here? So prognostication is typically performed on admission using a lot of the early scoring systems that we'll talk about. But it's using models to predict essentially short-term outcomes, and prediction of long-term outcomes during the first days of hospitalization does not fully capture the burden of disease, and it's going to create kind of this self-fulfilling prophecy. And so essentially this self-fulfilling prophecy is that, we have a belief about the future, mainly applying a short-term model prediction that is going to predict, say, a bad outcome based on admission characteristics for a patient. And because of that, there are actions taken because of having that belief. So we may recommend against aggressive care. There may be early withdrawal of life-sustaining measures, et cetera. And then because of those actions, patient either dies or has a worse outcome. And so essentially we're fulfilling that initial belief. So the result of the action then confirms the original belief. And as I was mentioning, most ICH prognostication models include baseline ICH severity factors, but are going to discount comorbidities, interventions, and any kind of hospital complications. Similarly, IVH grading typically accounts for baseline hematoma, but doesn't account for evolution or resolution or any components, improvement or worsening of hydrocephalus. And likewise, many clinical trials and IPH outcome prediction models looked at outcomes before 90 days, and there's really a paucity of systematic data beyond 90 days. And so just to kind of drive this home, this is actually an interview with Dr. Hempel that pops up underneath the IPH scoring system on MD Calc, where he kind of reiterates this exact issue. And he says, I've been overall surprised and disappointed at how many people use the estimates from the original ICH score to presumably predict outcome and communicate that to patients and their families. It's been extremely disappointing when I hear that patients aren't transferred to a higher level of care because of a high ICH score. And then he goes on to say, ironically, this has led me and others to study the self-fulfilling prophecy of poor outcome in ICH and other neurocritical care conditions if early DNR withdrawal of support is undertaken. So what is this paper specifically addressing? So they are asking the question, what are the one-year outcome trajectories among patients with ICH and severe disability at day 30? And so they have taken this group of patients who have an MRS of 4 or 5 at day 30 after admission, and they say, okay, well, how are they doing at 365 days later? In other words, these patients who are felt to have kind of a severe disability using early prediction scoring systems at day 30, how did they do a year later? And so just a brief overview of the methodology. So this was a longitudinal post hoc analysis of about 1,000 patients, and they used patients that were enrolled in CLEAR-3 and the MISTY-3 trials. And CLEAR-3 was the trial that was looking at spontaneous obstructive intraventricular hemorrhage with low volume intracerebral hemorrhage to receive IV thrombolysis, intraventricular thrombolysis versus placebo, and that was about 500 patients. And then MISTY-3 was spontaneous supratentorial ICH without obstructive intraventricular hemorrhage for patients to receive clot evacuation. And that was also about 500 patients. And so in this post hoc analysis, so they took those 500 patients from the CLEAR-3 trial, and at 30 days, there were about 345 patients that had an MRS of 4 or 5. And then they followed those, or they evaluated where those patients were at a year. Similarly, for MISTY-3, there were about 500 patients, 379 that had a MRS of 4 or 5 at day 30. And included those for a total of about 715 patients that were included in the final analysis. And the measurements that they looked at in this were, of course, age, sex, race, and ethnicity. They looked at stroke-related comorbidities, which included heart failure, AFib, CAD, diabetes, hyperlipidemia, anticoagulation use, CKD, COPD. They looked at DCS score and NIHSS scores. They looked at hematoma volumes and IVH severity. They looked at midline shift at the septum pellucidum and pineal gland. They looked at hydrocephalus using the Evans ratio, both on admission and at day 30. They looked at leukoariosis using a scoring system to kind of grade severity of that. And then in CLEAR-3, ICP and CPP were measured every 4 hours after EVD placement. Only about 14% of patients in MISTY-3 or MISTY-2 had MISTY-3 had ICP monitoring, and so that data was excluded. But they did look at the cerebral perfusion pressure from the CLEAR-3 patients. And then finally, they looked at adverse events and hospital complications, which those were actually adjudicated centrally during the treatment phase in both trials. And these adverse events included things like ischemic stroke, a new symptomatic ICH, cardiac events, ARDS, AKI, VTE, any infection, pulmonary events, etc. And so the primary outcome was that 1 year modified Rankin scale. And this was, these were blinded assessments. They were actually performed in both trials at 30 days, 180 days, and 365 days. And then the secondary outcomes they looked at were 1 year mortality, withdrawing of life-sustaining treatment, discharge to home, and then the quality of life EQ-VAS score that was self-reported at days 30, 180, and 365 in both trials. And just a brief point about an analysis. So they did dichotomize the modified Rankin scores into good and poor, and they included 0 to 3 in the good category. And traditionally, an MRS of 0 to 2 is most closely associated with functional independence, and previously used to define kind of a good or excellent functional outcome in clinical trials. An MRS of 0 to 3 was used here because this was classified as a good outcome in both CLEAR 3 and MISTY 3. And likewise, kind of the authors argue, you know, there's some more recent literature to suggest that ICH survivors with an MRS of 2 versus 3 report a similar quality of life. And there's also kind of considerable inter-rater disagreement between an MRS of 2 and 3, suggesting that maybe the categories have more overlap in terms of functional outcomes. Okay, so now getting on to some of the results. So let's first we'll look at the primary outcome of modified Rankin scale 1 year later. So on the left, we've got the patients from CLEAR 3 that had at day 30, this modified Rankin of either 4 or a 5. And so that was that total of about 345 patients. Then at day 180, they have 134 patients that have moved from that poor category into a good MRS category, and notably the majority of those are going to be in an MRS of 3. And finally, then at day 365, they now have a total of 153 patients kind of in that good category. And again, the majority are in the modified Rankin scale of 3 group, but there are, 23 patients here that have an MRS of 0 or 1, and 36 with 2. Similarly, on the right, so these are then the patients from the MISTY 3 trial. Again, modified Rankin of 4 or 5 at day 30. At day 180, there are 134 patients that have moved into the good category, and then at day 365, you have a total of 150 patients that have moved into the good category as well. And again, the majority are in the modified Rankin scale group of 3 here as well. Obviously, something really important to point out here is there are people that went the other direction, and in CLEAR 3, there were 77 deaths by day 365. So of this whole group, 77 patients died by the end of the year. Similarly, in MISTY 3, 52 patients died by the end of the year, and I'll get to that in just a second. So let's also look at the secondary outcome. Recall that patients were assessed via the European Quality of Life Scale, the EQ-VAS, which is a subjective scale from 0 to 100, again, looking at obviously quality of life. And so on the top, we've got the EQ-VAS trajectories in CLEAR 3, starting at day 30 and midpoint of 180, and then to 365. With this top blue line, these are patients that were in that good category, a good MRS category by day 365. These yellow dots are patients that were in that poor category by day 365. And then this dotted line at the top is the mean age-matched US population norm for the EQ-VOS. And so what you can see is that top group is kind of starting to approach that mean. So the patients that ended up in a good modified Rankin scale group. But both groups have an upward trajectory in the EQ-VOS. And we again see a similar pattern in the MISTI 3 group as well. And both groups, again, were associated with a statistically significant upward trajectory in EQ-VOS by the end of the year. And so what about that 1-year mortality? So about 22% in CLEAR 3 and 13% in MISTI 3 of patients with a poor 30-day outcome died by 1 year. And the median time to death was 85 days post hemorrhage or post ictus. About 15% of patients had delayed death from the index intracerebral hemorrhage. 9% died from other neurologic events, and they categorize those as brain death, herniation, recurrent hemorrhage, or hydrocephalus. It's a little bit difficult to piece out kind of, well, what's the difference from delayed death from the index intracerebral hemorrhage versus herniation? They didn't specify that further. And then 76% of patients died from non-neurologic issues. Withdrawal of life-sustaining treatment occurred in 31% of patients at a mean time of 73 days after that 30-day mark. So about 93 days after the event. And in hazards regression for the combined cohort, this mortality was associated with age, diabetes, female sex, severe leukoariosis, pulmonary edema, sepsis, and lack of IVH resolution. So some factors then that they identified that were associated with various outcomes. So diabetes was associated with poor outcomes. A higher NIHSS score, which they use an adjusted odds ratio here per point. Severe leukoariosis. Pineal gland shift as a proxy for midline shift. Persistent hydrocephalus at day 30. And new ischemic stroke, as well as a requirement of a gastrostomy. And also in the poor group specific to CLEAR 3 was cerebral perfusion pressure less than 60. And similarly in MISTI 3, poor outcomes were associated with a need for intracranial pressure monitoring. And then good outcomes were associated with radiographic ICH resolution at 30 days or IVH resolution at 30 days. Okay, and so I just wanted to briefly look at this. This is a figure from the supplementary materials, and this is looking at the receiver operator curves and area under the curve for 30-day models versus baseline models. And so how we look at this is essentially receiver operated curves are a way to look at the performance of a diagnostic test or the accuracy of a statistical model. So it's useful here in looking at kind of the accuracy of predictive modeling to estimate expected outcomes based on patient risk characteristics. And so this is going to plot a sensitivity on the y-axis and 1 minus specificity on the x-axis. This diagonal line is a receiver operating curve corresponding to random chance. So the area under the curve here is 0.5 equals 0.5. And as the model accuracy improves, this ROC curve is going to move towards the upper left. And the AOC is going to more closely approximate 1. And so we want it to go this direction. We want the area under the curve to be as close to 1 as possible for highest accuracy of the model. And what they show here is in CLEAR 3 model using the baseline model, which is what models that we typically use, and then the 30-day model. Similarly for MISTY-3, the baseline and 30-day, and then the combined models, baseline and 30 days. And the conclusion here is that, the 30-day event-based model strongly predicted one-year outcome with an area under the curve of 0.87, compared with models using the baseline severity risk factors alone at 0.76, to suggest that this is more accurate than using admission data baseline models. So finally, just some main takeaways. So what the authors concluded here were that about greater than 40% of patients recovered to a good outcome by 1 year, and about a third of the patients categorized as severe at 30 days were independent by 1 year. Nearly half of survivors with persistent poor one-year outcome were able to return home. And the findings also emphasize in those secondary outcomes that patients had an acceptable quality of life, or that an acceptable quality of life may be achieved among survivors, even who didn't have a quote, good functional recovery. They felt like, prediction of long-term functional recovery was improved after inclusion of more granular baseline characteristics. So things like diabetes, leukoariosis, the IVH volume, a midline shift, and incorporation of hospital events and complications. And the combined cohort experienced higher rates of good one-year outcomes than previously reported. And these data were less impacted by the withdrawal of life-sustaining treatment bias compared with other studies. There was 8.5% in the first month here, compared with 20 to 30% in prior studies. And they kind of propose a novel approach to prognostication that should be delayed until after the initial treatment phase, and incorporate hospital events. And should ideally promote early maximal treatment. And just a couple more things. So we talked about diabetes associated with a poor one-year outcome. Cerebral perfusion pressure less than 60 negatively influenced functional recovery, even when ICP elevation did not, to suggest that hypoperfusion may be more critical actually than intracranial hypertension, and raises kind of further concerns, frankly, with respect to blood pressure reduction in patients with large hematomas. Gastrostomy and prolonged ventilatory support was also associated with poor one-year outcomes. And then the complete resolution of IVH and ICH at 30 days was associated with better functional outcome. Ischemic stroke in the first month was also associated with lack of functional recovery, which is associated with leukoariosis. And so again, they say kind of, cerebral ischemic injury after ICH appears to be quite an important contributor to persistent poor long-term outcomes. And just some limitations of this. So, limited generalizability. These were obviously, this is analysis of two RCTs that had very strict inclusion criteria. And had different clinical kind of hemorrhage characteristics and interventions between the two trials. There's a question, if there's a type 1 error, meaning that the initial hypothesis, is rejected when actually it's true, because they did a large number of covariates and one-year outcomes. And then there's, perhaps some improvement or advances in ICH management over the 8 years of these studies. And then there were some missing variables that resulted in exclusion of patients in the multivariable analysis. So I'll just end on some final thoughts and questions. So these findings are in line with a couple other recent analyses. And so do people have thoughts on how we can start to incorporate relevant hospital events into prognostication? And then secondly, the current guidelines recommend aggressive care for all patients with ICH unless they've got clear prior documentation suggesting they do not want aggressive care for at least 2 full hospital days. But how long is reasonable 30 days is also not very practical, and should this be standardized? And so I'll stop there.
Great presentation, Amy. And I think a very challenging topic. You already sort of pointed out this 30-day thing. I'm not sure how well it helps, because most of the decisions for things like withdrawal of life-sustaining treatment were obviously going to occur before 30 days.
Yeah.
So how you would use this in terms of people presenting is going to be a little bit challenged. So what do people think about this? Yes, Claire, you raised your hand.
David raised his hand. I just unmuted myself, but I take it.
I saw your hand go up.
No, great presentation, Amy, and of course fascinating. You know what, the things we don't know is what happened to those people who died in those first 30 days, and maybe the decisions that were made prepared the survivors to survive well. So I'm not sure that this data at least helps us decide about the first 2 days. And I also think that, the longer we wait, the more we know, and the more accurate our ability will be to predict. 30 days seems like a very long time.
Yeah. I mean, it is pretty tough to know how to apply this. And people who get into randomized trials are different in so many ways than people who don't, either aren't recruited or refuse to participate. David, you have your hand up very politely.
Yeah, can you guys hear me okay?
Yeah.
I guess I agree with both of you about these 30-day predictions are tough to apply because exactly the decisions are made so early. But the thing that I walked away from this wondering about was, whether they mentioned anywhere whether all of the good outcomes were coming from the 4s or were they equally coming from the 5s. I didn't see that anywhere. And I wondered if they left it out on purpose because the 5s look pretty gloomy. Did you see anything anywhere on that?
No, I didn't. Yeah, I had that thought as well. I didn't. It's possible it's in the supplementary material, but they don't talk about it in the body of the paper. So it's a really good point.
How
I
about
think they try to accommodate that with like the EQ-VOS quality of life information, and they kind of hint at that, but yeah, they don't specify.
Somebody
How about
else?
distinguishing? I have 2 questions. One is, how about did they distinguish between clear and misty, or did I miss that? Because clear those are small hemorrhages with large IVH and are bound to, and at least I would think would do better. So did they distinguish between that? And then my second question is actually very different, but the EQ-VOS was completed by a mixture of patients and caregiver, I assume?
Yeah. They did differentiate. They did do differentiate between both studies, Clear 3 and Misty 3, and had pretty comparable 1-year outcome results.
We're going to have to close it down. I think the HPACS person is probably the neuroradiologist.
Oh, sorry, I didn't